Hey everyone. So today we're going to get into blunt thoracic trauma. This is all about what we can't see. So this quote is very true. Basically, thoracic injuries run the gamut from simple to absolute insanity. Now, I know in the trauma survey, we talked a little bit about how to care for a patient without a history. That's true. But the fact is, a good history is going to help not only guide our diagnosis, but how we treat our patients as well. So we want to get the mechanism of injury and a clinical history. And in this unit, we're going to talk about a number of injuries that can result from the blunt trauma. Some of them I'm going to mention in this unit, but we'll go more into depth in later units. Things like a diaphragmatic rupture can actually be in 4 different units, both thoracic and abdominal, but we'll get into that. In fact, some of these are even found in our med-surg units all over nrsng.com, so if you have a chance, check them out. So let's not waste any more time, guys, and we're going to dive right in. So when it comes to trauma, our assessments are really important, but they're pretty much always the same with any of our injuries. We do our ABCs, we look, listen, and feel, we trend our vital signs, and we send our patients to radiology, or we bring radiology to us in some cases. If we can get a good history, maybe we're going to look a little more at that specific area. If we know a guy was hit in the chest, I may not focus on his feet first. I won't forget his feet, mind you, but they may just not be first on my list. So a pulmonary contusion. Well, you guys all know what a contusion is, right? Like a black and blue. Well, we can actually get them on our lungs. Just like that black and blue mark on our skin, we get bruises on our lungs. So this is usually due to a rapid deceleration, like from a motor vehicle collision or some other sort of blunt impact to the chest. This is usually on the less serious side of things we see, but depending on the severity, we might have to intubate these patients. That being said, if a simple contusion is their only concerning injury, we just might put them on a non-rebreather and keep their O2 set between 94 and 98%. And that's kind of important. If we see the O2 set going down, we're going to have to address that. So just like the contusion to the lungs, myocardial contusion is a contusion to the heart. See, we have our little heart here, and he got a little bruise. I wouldn't put a Band-Aid on the heart, but you get the idea. Basically, it's caused by a direct cardiac impact, also known as a blunt cardiac injury. Treatment for this is really usually just monitoring, and that's done with serial EKGs and maybe some chest x-rays. So rib fractures and flail chest. When it comes to rib fractures, our treatment really depends on the severity and location of the fracture. A single hairline fracture down here at like rib 9 or rib 10, it's going to require a much different course of treatment than some compound rib fractures up here at 1, 2, and 3. And if you're wondering why, well, just picture the anatomy that sits under the ribs. You can see down at 9, 10, and 11, there's not much here. You got some open space. If we go up to the top, right, we got the heart, we got the lungs, we got the aorta, the great vessels, the subclavians. There's a lot more going on up there, so our treatment is going to be different. When we get a series of rib fractures, usually multiple rib fractures in 2 or more places, we call that a flail segment. If you look here, we've got a break here and a break here happening on 1, 2, 3, 4, way too many ribs. But this section here, we call a flail segment. It's basically a floating section of the ribs. It's not something we want, especially if we're near the lungs. We worry about puncture. Flail chest is also where we're going to see that paradoxical chest movement, right? Remember when the 2 sides of the chest are going in opposite directions. Now, trust me, guys, the first time you see this, you're never going to forget what it looks like. When it comes to treatment, the severity is the key, right? So simple rib fractures are going to get some pain meds, some monitoring, some O2, usually a same-day discharge. If they have multiple fractures and flail segments, they're going to require surgical intervention, and many of them go through a procedure called rib plating, which is just what it sounds like. Trust me. Google rib plating. Actually, wait a minute. If you Google rib plating, you're going to wind up getting menu pictures from a barbecue joint. Maybe Google surgical rib fracture repair. Yeah, that might work better. All right. Tracheobronchial injuries are just that. They're injuries to the trachea or bronchus. Easy. So obviously tears in these areas are going to cause issues with both airway and breathing. So we got to make sure to secure that airway. It's really our number one priority here. These type of injuries are where we're going to see something, it's a phenomenon called subcutaneous emphysema. And that's where air is leaking from somewhere and it gets trapped under the tissues in the skin. it looks and it feels like popcorn or like really small bubble wrap. It's a bad sign. Usually you see it as you're packing up, you got to go to the OR. And in actuality, I say that because if your patient has an injury bad enough to cause subcutaneous emphysema, I'd bet my paycheck that he's going to need surgery. So if you look over here, you can see how the trachea sits midline, right? Sitting right in the middle of the neck. So if you have a tear in the trachea, that's a tear. Sure it is. Just go with it. Basically, you're going to have air, as the patient breathes, you're going to have air escaping into the tissues of the neck, which is going to cause swelling as the air builds. And as the air gets under the skin in between the tissue, you're going to get that popcorn feeling. So that's subcutaneous emphysema. So pneumothorax and hemothorax. Both of these involve something that should not be in the chest, being in the chest. Pneumo means air. Hemo means, that's right, blood. Both of these things in the pleural space. Neither of these are good, and both can cause a partial or complete lung collapse. Just think of the air pressure building up or the blood that can accumulate in the chest cavity. In blunt trauma, there's probably not going to be an exit of the air or the blood that's leaking, so it's just going to start crushing things. If you look in the picture here, you can see that this is a nice, fully inflated lung, right? All this black space, your lung is being squished. All right, that is a compressed lung. This is all air. All right, this is all air. That lung is being crushed, and it needs to be treated. So treatment here is based on severity. Simple pneumos and hemos can be watched. Patient's probably going to be admitted for serial blood work and radiology, but may not require any interventions. The docs in those cases basically are hoping that the issues are going to heal themselves. More severe cases need a few things. In a severe pneumo, a first line of treatment can be something called a needle decompression. And that's basically the insertion of a usually 14-gauge needle, and it's inserted between the second and third rib, mid-clavicular line, and that's in an effort to let that air escape from the chest cavity. Now, while the ENA, the Emergency Nurses Association, does endorse ER nurses to perform this skill, and they do teach it, it is a facility-specific skill. So check with your educators or your managers to see if you're allowed to do it. So for both hemos and pneumos, the definitive line of treatment is a chest tube, right? This is a closed suction drainage system, and it allows for the release of air and fluids, but still maintains that proper pressure in the chest cavity. Now, while we can't insert a chest tube, it's of course our responsibility to assist with setting it up and monitoring it once it's in place, right? And then if all else fails, there is a thoracotomy, which is literally when we cut the patient's chest open to get the stuff that's in the chest out of the chest. It also helps to identify where it's coming from. We're going to talk about thoracotomies more when we talk about penetrating trauma. A pericardial tamponade is caused by some sort of bleeding from the heart itself. There's a hole in the heart and it's leaking. The problem is the pericardial sac here has not been punctured, so the blood that's coming from the heart has nowhere to go. Because of this, as we can see here, the pericardium fills with blood and thereby starts to squish the heart. If this continues, and we don't treat it, our patients are going to go into obstructive shock. It's basically a failure of the heart to pump correctly due to the compression, right? To treat this, well, you got to get the blood out of the pericardium, and we do that with a big needle, a procedure called a pericardiocentesis. We stick that needle through the chest, right into the pericardium, and we withdraw the blood. Now, this in and of itself should correct the tamponade, but of course we have to worry, well, the heart's still leaking. So our trauma docs may perform a procedure called a pericardial window, which is just what it sounds like. It's cutting a hole in the chest to visualize the heart, locate the problem, and hopefully fix it. An aortic disruption, it's basically any tear or separation in the aorta. Now, if you think about how much blood the aorta carries and where it goes, if this is our heart, I'm sorry, that's a terrible heart, but our aorta goes everywhere, right? This is our aorta. So if you picture any disruption along that line, you can imagine the amount of blood that can be released. These patients are going to bleed out very fast with a true separation or dissection. They're going to require massive transfusions and most likely surgery. Now, one sign of a true dissection, if this is basically cut in half or opened, you're going to see significant differences in the pulses in the upper and lower extremities, right? By the way, if the guy's legs are turning blue, it's probably a good sign that he isn't getting any blood down there, right? So if you suspect this, check the pulses upper and lower. Myocardial rupture is exactly what it sounds like. Whatever happened to them, it caused the heart to basically open up, to explode. The heart's ruptured. If somehow these guys manage to live long enough to survive the transport to the ER, they need immediate surgical care. This is the kind of case on like ER or Grey's Anatomy when you hear that trauma doc say that he has a finger in the guy's heart plugging the hole. This isn't common, but I'll give it to him. This actually does happen. So if you see that, well, then you know what happened. Diaphragmatic ruptures, we're going to talk about a little bit more in our abdominal units, but for now, you know it's something that can happen with thoracic trauma. And the reason we want to know about it is because the abdominal contents in a diaphragmatic rupture can actually leak into the thoracic cavity. And we're going to talk about why that's bad later. These patients need to go to the OR. End of story. You got to repair that rupture. I want you guys to remember that blunt trauma requires us to use our clinical judgment as we can't see many of the injuries, right? Everything we talk about is based on evidence. Everything in trauma care these days is based on evidence-based practice. And of course, with chest trauma, we always want to keep that O2 sat in mind, right? So guys, I never want you guys to forget the basics. As always, it's all about airway, breathing, and circulation first, right? Now, just because you can't see the blood doesn't mean the guy's not bleeding. You have to look for other signs. We always want to try to get that mechanism of injury. You want to try to get as many details about the incident as possible. It's going to help us treat. With any trauma to the chest, we always want to keep those concurrent injuries in mind. You know, if the ribs are fractured, are the lungs involved? Are the great vessels involved? I always want you to think if one injury can lead to another, right? And as always in the trauma bay, use your tools. Fast exams, chest x-rays, whatever you have, use it in order to help you diagnose. Thank you guys so much once again for joining us on our trauma journey. And as always, happy nursing.